So, respected Chairperson, Professor Bahani Sangarship, Department of Psychiatry, Institute of Mental Health, SUM Hospital, Bhubaneswar. And today's speaker, Professor Dr. Balaji Bharadwaj, Department of Psychiatry, JIPMER, Pondicherry. And today, moderator, Dr. Asud Babu, Dr. Pradeepa, consultant psychiatrist of Snega Mindcare Hospital, Tirunelveli. My dear colleagues, practicing psychiatrists and postgraduates, very good morning to all of you. I extend my warm welcome to all of you in this Sunday. Indeed, it's a great privilege for us to organize this All India Evolve Teach webinar. And we have been conducting this Evolve monthly webinar almost for 2 years, and every fourth Sunday between 11:30 a.m. to 12:30 p.m. And there is a overwhelming response and support for this webinar among the postgraduates and also from the practicing psychiatrists across India. And we are choosing the topic that is more relevant to the postgraduates. And the speaker of this webinar is usually a well-known and eminent personality, and the chairperson also will be is a senior postgraduate teachers. The webinar is not only beneficial for the postgraduates, but it also refreshing for the practicing psychiatrist. I am thankful to Dr. Babani Shankarship sir from Odisha and Dr. Balaji Bharadwaj from JIPMER, Pondicherry, for accepting our invitation and joining this webinar in spite of their busy schedule. And today's speaker is Dr. Balaji Bharadwaj. He is from JIPMER, Pondicherry. He is an eminent postgraduate teacher who has been teaching for almost 14 years. And he has more than 50 publications. And this Dr. Balaji Bharadwaj speak about alcoholism disorder in emergency and other medical settings. I hope this webinar will be definitely useful for the postgraduates and as well as the practicing psychiatrists. With a small introduction, I'll hand over this session to Dr. Aswath. Yes, Dr. Aswath, over to you, Dr. Aswath.
Yes, sir. Thank you, sir. Warm greetings to everyone joining us today for the Evolve Monthly Psychiatry Lecture Series. I am delighted to see such a vast audience from across the nation who have made this program a grand success till date. Very good morning to all the respected seniors and juniors present here. Myself, Dr. Ashwath Babu, currently working as consultant psychiatrist at Snega Mindcare Hospital, Tirunelveli. I will be moderating today's session along with Dr. Pradeepa, consultant psychiatrist, Tirunelveli. First and foremost, I would like to express my sincere gratitude to our course director, Dr. C. Panniselvan sir, whose vision and leadership have made this lecture series possible. Before moving on to the session, I would like to announce previous session's quiz winners. Dr. Pranjal Tripathi from Andhra Medical College, Dr. Indumati from GMKMC Salem, Dr. Rohini G from KAPV Government Medical College Trichy, Dr. Srivaramangai Kumareshan from Savita Medical College Chennai, and Dr. Kalai Selvi from Tirupur Medical College. Likewise, we'll be having today quiz also. Our speaker for the day, Dr. Balaji Bharadwaj sir, will be asking 5 questions in between the presentation. The participants are instructed to type their responses in the chat box. First 2 members giving the correct answers will be selected as winners for each question. The winners will be announced in the next session. On that note, I move on to introduce our esteemed chairperson for the day, Dr. Babani Shankarship. Sir is currently working as professor at the Department of Psychiatry, Institute of Medical Sciences and SUM Hospital, Bhubaneswar, Odisha. Sir, we are truly honored to have you with us today, sir. Now I humbly request you to introduce the topic for the day, sir. Over to you, sir.
Alcohol is disorder, and alcohol is very commonly used nowadays from student to many people. They all use alcohol. It's a part of our society now. Okay, so the alcohol-related problems are also very much common. So we must know a little bit of some aspect of alcohol-related disorder, and hope it will progress in a good way. So let's progress.
Thank you, sir, for setting the stage. Now I request Dr. Pradeepa to introduce the speaker for the day.
Good morning, everyone. Am I audible?
Yes, ma'am, you're audible.
Thank you. I'm a consultant psychiatrist at Snega Mindcare Hospital here in Tirunelveli, and I'm glad to introduce the speaker of the day, Dr. Balaji Bharadwaj. He is currently an additional professor at the Department of Psychiatry, JIPMER, Pondicherry. He did his undergraduation in AIIMS, Delhi, and postgraduation from NIMHANS, Bangalore. He He has over 14 years of experience of postgraduate teaching in psychiatry and in addiction psychiatry. He has worked on the development of a scale for assessment. Hello?
Yes, proceed.
He has worked on the development of a scale for assessment of severity of substance use disorder in association with NDDTC in AIIMS, Delhi. He has 54 indexed publications, and his other areas of interest are peripartum psychiatry and consultation liaison psychiatry. And we are looking forward to hear from you, sir. Over to you, sir.
Am I audible?
Yes, Dr. Balaji, sir.
First, I would like to thank Dr. Paneerselvan sir for kindly inviting me. I thank Dr. Bhavani Shankar sir for chairing the session, and the moderators, Dr. Ashwath and Dr. Pradeepa too. So today the topic of the presentation is on handling alcohol in emergency and referrals. So first, I would like to declare that there's no conflict of interest that I have with respect to this topic, and I've made some fair use of tables for purpose of education. Also, I would like to remind that in medical sciences, never is never right and always is always wrong. So there'll always be some plus minus in certain slides where people may have some questions. So first thing, as psychiatrists, as residents, we are often called, there is a referral given to us and we are often called to the emergency department or to another ward with respect to alcohol. With respect to alcohol use disorders. So it is said that about 30 to 50% of cases coming to accidents and emergencies department is related to alcohol use. But do they really call us for every alcohol user who comes to the emergency? Or is there a certain threshold when they call us? So this is the first thought which should strike our mind when we go to attend a referral. Why did they call us for this patient? And usually it is the presence of a behavioral problem. Now, these behavioral problem, we must remember, can be either due to directly related to substance use or substance withdrawal, or it is more likely in the emergency setting to be related to medical causes or sometimes other psychiatric ailments. So this is a very important area where we need to go and give our expertise as psychiatrists. So for a behavioral problem, they call us, and if it is, if there is no substance use, then usually the two kinds of calls are for functional psychiatric illness or medical causes of delirium. But if there is substance use, we often face this dilemma, and we need to see whether it is dependence or not. If there is no dependence, then again it goes to psychiatric illness or a medical cause of delirium. But if it is alcohol dependence, then comes the real problem. And this section D here at the bottom of the slide is where we would be dealing with in this topic or in today's talk. So is it due to a medical cause of delirium or behavioral problem, or is it due to delirium tremens or alcohol withdrawal delirium? So the first and foremost point is that we need to establish dependence. This is a very important aspect, because people with alcohol dependence are those who have a certain degree of problems, a certain severity of problems which can occur. So that is the first thing that we need to establish. And we use standard criteria. We use either the ICD-10 or now many centers have started ICD-11 criteria, or if we are using in the habit of using DSM, we can use that. But why do we need to establish dependence? Dependence is very important to establish because patients who are dependent will invariably require some medication prescribed from our side to prevent severe alcohol withdrawal. If they are not dependent, just advice may suffice for most of the other patients. In the EMS or the emergency medical setting, or when you see a cross-reference in another department as a consultation psychiatrist, what is the purpose of defining dependent? The main purpose boils down to the immediate term risk and benefit of prescribing benzodiazepines. So if a patient is medically ill, risk of benzodiazepine causing some adverse effect can become high, whereas if the medical illness is less severe, then the risk of not prescribing benzodiazepine and having severe alcohol withdrawal can become high. So it is to balance that risk and benefit is where we need to define dependence. So what is the most important criteria? If some of you PGs can try to type it in the box, what would be the one important criteria which is very important in our decision making? So if we can have some answers. CIWA, okay, CIWA-Ar score can be done. Withdrawal symptom, yes. So, no, Dr. Kirtana Arun has typed that withdrawal symptom is the most important one because that sort of defines a certain degree of risk. So we need to document this and to document it briefly. So this is one important graph. You know, when a person drinks alcohol, he's not yet addicted to alcohol. What happens is the balance is tilted in favor of the CNS depressant side. So there is GABAergic tone in the brain and alcohol adds to it. So an occasional user gets intoxicated with alcohol. This is how the balance in the brain is. Whereas somebody who is using alcohol every day in a heavy use on a daily basis is there, the GABA and alcohol get balanced by an upregulated glutamatergic system in the brain. So this is called as allostasis, that is a homeostasis at a different level called as allostasis. So the person who is drinking every day in a heavy manner, heavy alcohol use is there. Suddenly when they stop alcohol, when the alcohol is no longer there is net excitatory excess in the brain. The glutamate, which is upregulated, goes unopposed. And therefore, always the alcohol withdrawal state that we is always an excitatory state. There is always agitation, there is palpitation, anxiety, autonomic overactivity, autonomic overarousal, hallucinations, and a form of hyperactive delirium. This is very important for us to remember. Always alcohol withdrawal state is a state of increased excitatory neurotransmission in the brain. This is another very important slide to remember, the time course of alcohol withdrawal. Very important to remember, whether or not we give treatment to the patient, this is the time course of alcohol withdrawal. There may be many patients who are alcohol dependent. They stop drinking alcohol but never come to a doctor. And this is what they will face at home, even without any treatment. So the minor withdrawals may start from about 6 hours after the last drink, becomes mild withdrawals will be there and last between 3 to 5 days. Whereas those who face more significant physical withdrawal, the moderately severe withdrawals, it may last even up to 5 to 7 days. It is a little more severe, can start little earlier than 6 hours and can last 5 to 7 days. The three graphs at the top are those for complicated withdrawals. Seizures can happen as early as 6 hours after the last drink when the patient has not yet had moderate to severe withdrawals set in. This is very important. Many of us, you will remember, we have seen patients coming for alcohol dependence treatment. They are waiting for us. We are seeing a patient. They're still waiting for us. They don't seem to have withdrawal. They don't seem to have sweating, but suddenly they throw a seizure. Haven't we had this experience? That is solely because seizures can happen even before the physical signs of withdrawal are evident. So it is very important to check for past history of withdrawal seizures and to immediately initiate benzodiazepine treatment for such patients. Alcohol withdrawal hallucinations can occur. It usually starts between 12 to 18 hours or within the first day after stopping alcohol, lasts for between 5 to 7 days. Then we have delirium tremens, which usually has a lag of 48 to 72 hours from last drink. And after that, it increases in intensity and comes down, and it may last between 5 to 7 days or rarely up to 2 weeks. So this is the important chart. Very often you may get a call from the surgery department saying patient with acute pancreatitis, we have him in our ward for 3 weeks. He is having chronic heavy alcohol use. Now he is in delirium tremens. Delirium tremens cannot start after 3 weeks of stopping alcohol. It has to be either sepsis or electrolyte imbalance or definitely something else. So this is a very important slide for each one of us to remember. And this I have already elaborated in the graph. So minor withdrawal and moderate to severe withdrawal, and their timelines are mentioned here. So we'll just discuss with one particular case. A 35-year-old man is admitted with fever and cough, and he reveals alcohol use to the medical resident. History of alcohol use is there. The man appears slightly anxious. So the resident sends for a psychiatry referral immediately on the evening of admission. So how would we approach this case? Should we prescribe any medications or not? So can we have a few answers? Would we prescribe medications or not? Okay. So the last average use is required. So the last use was just 1 day before the admission, and he uses about 6 units per day. 6 to 8 units of alcohol per day. 1 to 1.5 quarters of IMFL every day. And we assess for dependence pattern. Very good. Yes, we assess for the dependence pattern. He is having dependence, but he has not yet started having withdrawal symptoms. So what should we do? Should we prescribe? Benzodiazepines needed. Okay. Now we will assess the withdrawal symptoms. Yes. Okay. Thank you. So this is a very important one. Commonly, we get this. Sometimes the medicine resident may have seen a case go into DT, and then they will be more aware the next time and they refer very early. So in the situation that the referral is received on the day of admission, then you look for the risk of developing complicated withdrawal. So what is the likelihood that the person can develop complicated withdrawal? But there are no withdrawal signs yet. So for that, there is a prediction of alcohol withdrawal severity scale. So Nadu has developed it, and there is a question which asks for any recent alcohol use within the last 1 month. They have used a very extended timeline, but that's how the questionnaire goes. And they also check for blood alcohol level, which many times we may not have it immediately, maybe non-functional. But there are a set of questions that is asked in the scale. Have you been recently intoxicated within last 30 days? Have you undergone treatment for alcohol use? So again, it's a soft marker for dependence. Have you experienced previous episodes of alcohol withdrawal? So someone had rightly said, we have to take history of alcohol withdrawal in the previous episodes. Another indicator of severe or heavy drinking is of blackouts. Has anyone experienced alcohol withdrawal seizure or delirium tremens in the past? They are at higher likelihood of developing complicated withdrawal. And if they are combining along with benzodiazepines or barbiturates. So these are some of the key questions on interview. So this is what we do in our clinical practice. And we also look for any evidence of increased autonomic activity. This is very important. Like I had said, increased glutamatergic transmission, increased excitatory neurotransmitters in the brain, autonomic arousal signs will be evident. So these are some of the risk factors for severe alcohol withdrawal. Older age and longer duration of dependence, having comorbid medical or surgical illness, past DT or withdrawal seizures, severe withdrawal symptoms if they have already developed, comorbid medical condition like dehydration, hyponatremia, hypokalemia, abnormal liver enzymes, lower the platelet count, marker of more heavy alcohol use, and if there are already structural brain lesions. So one of the things that is said in literature is duration of alcohol use and daily alcohol use is not a consistent predictor. Here we would slightly differ from what literature suggests. what we actually see in experience, you can use it as a rule of thumb. Somebody with 5 or more years of dependence using 6 or more units of alcohol per day and using for 4 or more days per week. As a rule of thumb, we need to be more careful that these patients are likely to experience significant withdrawals. So how do we manage further? So should we start benzodiazepines or no? Somebody had rightly pointed out that yes, we may need to start benzodiazepines, or should a more proactive consultation liaison team go and frequently monitor the patient on a day-to-day basis and initiate withdrawal only when the withdrawal signs start. So here I would like to remind that we have 3 approaches for detoxification, or the newer term for the same is acute withdrawal management. So for alcohol detoxification, fixed dose regimen. We generally start with a fixed dose of lorazepam or diazepam or chlordiazepoxide based on average daily use of the patient. Like someone had rightly asked, what is the daily use? You start a fixed dose based on that and gradually taper over 3 to 10 days. The other method is using front-loading regimen. Usually a long-acting benzodiazepine like chlordiazepoxide or diazepam is given frequently by mouth per oral at short intervals of 2 hours so that the long-acting benzodiazepine and its long-acting metabolites accumulate, the patient becomes sleepy and then goes to sleep. This is the front-loading method. The other one is called symptom-triggered, that you just wait and watch, and if the symptoms exceed a certain threshold, crosses a score of 10 on CIWA-Ar, then you administer a single dose of benzodiazepine then and there. These are the 3 broad methods. So in the case that we discussed, which of it can we use? So if a patient is at risk of severe withdrawal, what we do is we can consider symptom-triggered regimen if the patient's general condition is sick. So if the patient is having, say, pneumonia where there is desaturation, medical condition is sick, then you may want to have a wait and watch approach, provided our resident psychiatry team can also go periodically, or the nurses in the ICU where the patient is admitted are also trained to watch for withdrawal symptoms and alert us immediately. So that would be one good approach. Or a fixed dose regimen is better for OPD patients, OPD referred patients, or a patient where a general condition is fair, it is not poor. So these can be used. Generally, we avoid front-loading regimen in a cross-reference setting or emergency setting. We avoid where there is medical comorbidity, because we are using long-acting benzodiazepines, and if they tend to accumulate and patient has an adverse effect, the reversal of adverse effect takes a longer period of time. Hence, it is generally avoided where medical comorbidity is a concern. So here we have another case. A 24-year-old man is brought to the emergency in a state of agitation and confusion. He fell from his two-wheeler when riding under influence of alcohol just 6 hours back. And he has daily alcohol use for last 3 years, using about 4 units of brandy each day. And he's brought to the emergency services. So here, what could be the diagnosis and appropriate management? His pulse is 58 beats per minute. Blood pressure is 170 by 110 millimeters mercury. He is disoriented and has profuse sweating. So can we have some answers? What is the most likely cause of this patient's delirium? Alcohol withdrawal syndrome complicated with seizures. Okay. Yes. RTA and head trauma is more likely. Okay. Fine. So this is a young man and he has his last use of alcohol was just 6 hours back. So if we remember the timeline, onset of delirium tremens is usually after a lag of 2 to 3 days. 48 to 72 hours after last drink, person goes into delirium. We can consider alcohol withdrawal delirium or DT. But here it is very rapid. And another red flag sign is he has a high BP along with bradycardia. The pulse rate is low. This may indicate, this I have put as an indicator for the raised intracranial tension. And there is also disorientation to time and place. He is already in delirium. So as someone rightly pointed out, I think Dr. Saptarishi had pointed out that RTA and head injury may be the more likely cause. So now let us take another man who is 44 years old. He is brought to emergency with agitation and confusion. He has also fallen from his two-wheeler while riding under influence of alcohol 3 days back. So he has been having daily alcohol use for last 23 years, using 12 units of brandy each day. After this minor accident 3 days back, family members prevented him from going and drinking alcohol. And since this morning, he is confused. And on examination, he has pulse of 120 beats per minute and BP is 150/90, profuse sweating, tremors, and disorientation. So in this case, what would be the diagnosis and management? So benzodiazepines and DT is the quicker answer we have got this time. So there is a lag of 3 days. And when the family members prevent him from drinking alcohol, saying, no, you'll have an accident. He does not drink for 3 days. Thereafter, he goes into delirium. So hence, it's more likely to be delirium tremens. But still, you need to do a thorough neurological examination and rule out, because he's 44 years old, there could still be some head injury. It's a good idea to do a thorough neurological examination also. So assessment of withdrawals in the medically ill, the key dilemma we face are to determine which clinical signs and symptoms are suggestive of alcohol withdrawal versus due to medical condition, and what is the safe dosing strategy with benzodiazepines in patients having a medical comorbidity. So like someone had already pointed out, CIWA-Ar scale is the most commonly used scale. It has 10 items. But the key disadvantage I find with the CIWA-Ar scale is it does not have items like tachycardia, high blood pressure, which are markers of autonomic arousal. So we may get tricked into it. And you can also do this experiment. You can simply apply CIWA-Ar for a lady who is in medical ICU, who is in delirium, who has never taken alcohol. Even other delirium could possibly score high on CIWA-Ar. So CIWA-Ar is not diagnostic. Diagnosis is still based on clinical history and basic examination. And CIWA-Ar we use for severity rating alone. This is the CIWA-Ar scale. I think everyone is familiar with it. I think it's the most commonly used scale. There is another scale which we less commonly come across. It's the alcohol withdrawal scale, which is 11 items, and it has 2 subscales, somatic subscale and the mental subscale. So the somatic subscale is very nice. It has pulse rate, diastolic blood pressure, temperature, breathing rate, sweating, and tremor. So it gives a lot of value to these signs of autonomic overarousal also, in addition to the mental symptoms of withdrawal and withdrawal delirium. The other scale which I have come across is the brief alcohol withdrawal scale, which has just 5 items: tremors, sweating, agitation, disorientation, and hallucinations. Again, it's a nice scale which has good focus on autonomic arousal signs, and being short, it can be easily applied in the emergency or reference setting. So this is the brief alcohol withdrawal scale. And another very quick to use scale is the short scale. Short is a 4-item scale consisting of sweating, hallucinations, disorientation, and tremors being the 4 items. And it has good specificity and sensitivity when compared to CIWA-Ar, was given by Gray et al. So these are the 4 items. I prefer to use one more item, SHOTT, I try to make it, which is the fifth item would be tachycardia. If you can add tachycardia to this, would be very much useful. So as we went through the scales, to sum it up, CIWA-Ar is most commonly used in our psychiatric setting, covers a wide range of symptoms. However, autonomic arousal and physical signs of withdrawal, the key signs which prompt us to decide on appropriate dose of benzodiazepine, is missing in CIWA-Ar, and we need to still rely on clinical examination or some of the other shorter scales which I had mentioned. So this is important: sweating, hallucinations, disorientation, tremors, tachycardia, and hypertension and agitation. These are markers of significant physical withdrawal. Next one. So we have now so far taken a couple of cases where even OPD treatment or some basic question is there. Now we'll go to a little higher level of complexity. A 42-year-old man presents to EMS with 12 years of daily alcohol use, using 12 units of brandy until Saturday evening, 7 p.m. And on Sunday morning, he was brought to the emergency department with complaints of hematemesis and passage of black tarry stools since morning. Now, he has a pulse of 120 per minute and blood pressure is just 90/60. He is dehydrated, drowsy, confused, speaks incoherently, has a distended abdomen, which is also dull on percussion. So what could be the possibilities? It's a surgical emergency, hepatic encephalopathy, Boerhaave syndrome. Okay. So all of you have clearly put it in the domain of the medical or surgical team to see. No, this is definitely not a patient we would be admitting into our ward right away. That everybody is really clear about it. Now, he was managed under surgery for hematemesis. He was not referred to psychiatry, but they had started him on chlordiazepoxide 10 milligrams 3 times a day for last 2 days after taking a medicine opinion. Now, Tuesday evening, he was noted to be agitated, picking up imaginary cigarette stubs from the bed, calling out to his sons as if he could see them around in the ward. And when we go and examine, his pulse is high at 120, BP appears normal, he has sweating and tremors. And that day's liver function test is also deranged. So what could be the cause here? Delirium tremens, hepatic encephalopathy, medical delirium, hepatic encephalopathy. Okay, I think we have more votes in favor of hepatic encephalopathy rather than delirium tremens. No, but still, no, there are some other signs. So one thing to note is that we are now entered into the window of 48 to 72 hours from the last alcohol use. No? So we have entered the window where the delirium tremens component will also start to contribute. But of course, he is also medically ill. No? So you get some signs like sweating, tremors, and tachycardia you are getting. And then he's also agitated. He's also picking up imaginary cigarette stubs or threads from his bed, which many of our patients with DT will do. But then the signs of medical problems or comorbidity is also unmistakable. We cannot ignore them also. So this is possible that it is a mixed kind of delirium. So in this, no, we would all agree that no, chlordiazepoxide may not be the optimum choice, being long acting. Then we would prefer to go for lorazepam if at all, a certain dose of lorazepam, and we may also have to go for a certain dose of haloperidol. Possibly there are both components to the delirium. So we advise a change over to lorazepam, about 8 mg per day, for the amount of agitation and tachycardia that he has, but not to exceed a certain dose. And then the next evening we receive a call that patient is in catatonia. He is stuporous, not easily arousable, mumbles incoherently. So then again, now we have gone, the pendulum swings in the opposite direction and the patient goes into a hypoactive delirium-like state. So This is one important problem that we face. At a more complex level, we see patients with delirium, and we need to see the components of medical delirium and delirium tremens. So this is the assessment of delirium. It's called confusion assessment method. It's a clinical method where acute onset fluctuating course of inattention is there, and patient has disorganization of thinking and altered level of consciousness. So both 1 and 2 must be met along with either of 3 and 4. So this is the clinical method of assessment of confusional state or delirium, which we use in a consultation setting. The same thing has been made little more objective. It's called CAM-ICU, where fluctuating mental status is there and there is inattention on bedside examination. So you read a series of letters, and when they are asked to tap on the sound when you call out a particular letter. So it's made objective. But otherwise, the criteria is very similar, that both 1 and 2 must be met and either of 3 or 4 must be met. This is called the CAM-ICU method. This is important because we have the Richmond agitation scale, Richmond agitation and sedation scale, class scale. That is very important. So when we think of delirium, we must be aware that delirium can be of 3 types depending on the psychomotor agitation or retardation. It is classified into hyperactive delirium where agitation predominates, hypoactive delirium where there is sedation or stupor predominates, and mixed delirium which presents in with a fluctuation between the 2 poles. One important thing to remember is DT is likely to present with hyperactive delirium rather than other 2 types. So if you have a patient presenting with DT, you initiate medication, you admit in psychiatry ward, you initiate medications, and next day patient goes into hypoactive delirium, you have to relook and check for any medical or neurological comorbidity which we may have missed at the time of admission. This is a very important warning sign that a patient with DT should not go into hypoactive delirium. So when do we suspect medical comorbidity? This could happen even in our ward if we by mistake admit some patient with comorbidity. So if there is absence of substance dependence at all, or if there are autonomic or the lack of autonomic signs of withdrawal are there, then the DT likelihood goes down. You have to recognize specific patterns of withdrawal and the specific time course of withdrawal, which is very important. And recognizing the delirium as hypoactive or mixed, then it should alert you. And if you see that seizures or DT is not responding to adequate benzodiazepine dosing, one rule of thumb that we always learned as resident is, if a DT patient is treated with benzodiazepine, he has a good overnight sleep. Next morning, he is not supposed to be in delirium. The delirium must have resolved. If it has not resolved, kindly again recheck for any medical comorbidity. And patient goes into hypoactive delirium with initial doses of benzodiazepine is a warning sign for medical comorbidity. And if there are any atypical presentations. Typically, withdrawal seizures are generalized tonic-clonic seizures, which are discrete episodes. We usually don't have focal seizures unless the patient has a comorbid condition. And status epilepticus also does not happen in DT. So these are some of the important atypical presentations we must be aware of to detect medical comorbidity and warn our medicine colleagues accordingly. The most commonly encountered medical comorbidities are hyponatremia, sometimes aspiration pneumonia, hepatic encephalopathy, head injury, or any other drug overdose along with alcohol, and then the other medical causes would come. One important aspect about aspiration pneumonia is it may not manifest on the day of admission. No? So we may admit a patient with alcohol withdrawal seizures, but he may have slightly aspirated. The right middle lobe will get consolidation only after a lag of 2 to 3 days. So any patient of alcohol withdrawal you admit in the ward, the first 1 week we have to be on high alert for any signs of medical comorbidity. Some of these complications have a delayed presentation, or the signs symptoms may show up in a delayed manner. So this we have gone through. Pitfalls of CIWA-Ar are there, and important thing is to relook clinically. You always ask yourself again and again, is it still DT? On the day of admission, I made a diagnosis of DT, but today it looks different. Is it still DT? We need to keep asking ourselves. Don't keep the diagnosis of DT set in stone. So the multifactorial delirium or overlap, when it is there, we need to tease out the two components of alcohol withdrawal delirium and the medical component of delirium. And the short signs are very useful. Like I said, sweating, hallucinations, disorientation, tremors, and I add tachycardia also to it, which can be quickly checked clinically. Look out for the agitation or hyperactive component. And also remember that DT has its own time course and improves regardless of treatment. And we just titrate the benzodiazepine to this component. And it's more of a clinical call. Like I said, there'll be some parts in this presentation where I do not have an exact answer from evidence-based medicine. This falls into the domain of taking a clinical call. So clinical judgment is important. Alcohol withdrawal is minor and medical disorder is major. Means it happens sometimes shorter duration of dependence, low daily consumption of alcohol, absence of short signs, absence of agitation, then benzodiazepine requirement may be minimal. But if the medical disorder is minor, being treated on OPD basis, alcohol withdrawal is major, prominence of short signs will be there, agitation and autonomic arousal will be there, then benzodiazepine requirement may be little higher, but still caution needs to be exercised even in such patients. So this is how we titrate. Generally, what we do in our practice is for multifactorial delirium, we go for a lower dose of benzodiazepine, 6 to 8 mg or up to 10 mg of lorazepam per day, compared to a full dose of 16 mg per day, which you would give for a patient in our ward or in our OPD without any medical complication. This is because greater risk of complications can be there with benzodiazepine if there is medical comorbidity. They are more sensitive to side effects. And lower dose, we hope, will prevent seizure and reduce the degree of agitation and may not worsen the delirium, is what we hope. And we, in our practice, we use adjunctive haloperidol, or nowadays even risperidone is taking its place, 0.5 to 1.5 mg per day. It treats the medical delirium component, and we usually continue it for around 3 more days after the underlying medical condition has been treated. And we use it intramuscular also if required, especially if patient is extremely agitated. So this is just a typical chart of how we dose the medications. So somebody is having bilirubin is high and AST ALT is high. So this is more of liver disease is there. So in such a patient, lorazepam 6 mg may be there and it is quickly tapered, and they are also on haloperidol. So typically this is how it is done. And there is another patient where again there is liver disease, but which is more like acute alcoholic hepatitis, and which is rapidly reducing over the first 7 days. The bilirubin is improving fast, and he does not go into drowsiness or stupor, but remains agitated, awake. In such cases, the dose of lorazepam seems to be a little more higher, and haloperidol is required only SOS. This is just a rough chart I've taken from 2 imaginary patients from our wards, or 2 previous patients from our ward. Fine. So this is covers the main portion, and the rest I will leave it for some questions, because I think we are nearly reaching the end of the time also. So this I have kept these slides mainly for answering certain questions which residents may have. Thank you, sir. I hand over the mic to the floor.
Sure, sir. Thank you, sir. Thank you for the lucid presentation, sir. You kept the audience hooked right from the beginning till the end, sir. Now I request the chairperson, Dr. Bhavani Shankar Shit, sir, to give his comments on the speech.
It was a nice class, and everything was very important things. And we also know a little bit of something, but in a systematic manner, it should be periodically reviewed. Okay. And sir did not speak about the role of thiamine, benfotiamine. I think in the next coming class, you may say something regarding thiamine, benfotiamine, or other vitamins. It is also equally important in the case of alcohol withdrawal. Okay. But everything was right. Okay, thank you. Thanks, student. Okay. Thanks, sir.
Thank you for your comments, sir. Now, sir, we shall take few questions if time permits,
Role
sir.
of Dr. Balaji, he is talking about the role of thiamine in these withdrawal symptoms.
Thiamine is very important because in practice, we cannot distinguish between delirium tremens and Wernicke's encephalopathy because ataxia, many patients will have ataxia due to either Wernicke encephalopathy or alcohol-related cerebellar degeneration. We don't know which is which. Global confusion is part of Wernicke encephalopathy and delirium tremens. So in practice, if a patient comes with delirium tremens, it is a good practice to assume that there is also Wernicke encephalopathy. We cannot distinguish at the bedside at all. So we have to give high dose of thiamine. So minimum of 600 milligrams per day to up to 1,500 or even 2,000 milligrams per day of thiamine is described. That is important. Other important aspect to thiamine supplementation is it has to be parenteral. No? If we go back to our biochemistry textbooks, there is a limit. A single oral dose of thiamine, body cannot absorb more than 10 milligrams. So it is very important to supplement thiamine parenterally. That is very important. So as sir has pointed out, the role for thiamine supplementation is important parenterally. So in our practice, what we do is if it is uncomplicated alcohol withdrawal only on OPD basis we are treating, we may give a single shot of parenteral thiamine and the rest as tablets. But for all admitted patients, at least once a day, about 250 to 500 mg of thiamine minimum we are giving. And delirium tremens, definitely minimum of 500, 600 mg per day. Thiamine parenterally we are giving till the delirium resolves.
Comments by our course director, Dr. C. Panneerselvan, sir. Sir, can you please give in your comments about the session, sir?
Yes, Dr. Balaji has done a very wonderful, very informative presentation. And I thank Dr. Bhavani Shankar sir for spending his valuable time to start the session, which is Sunday. And I thank my colleague Dr. Aswad Babu and Dr. Pradeepa and all the participants for their active listening, and also they participated in the discussion. I've seen many people they have answered the questions when the speaker asked for the question. They have answered very nicely. And the YouTube link for all these sessions is available. Current session also the previous session is also available in the YouTube link. Anybody want, you can contact the East West Pharma for the link. And I thank the East West Pharma for sponsoring this Evolve program almost for the past 2 years. With this, I close the session with a vote of thanks from East West Pharma.
Thank you, Doctor. And East West, first of all, East West Pharma saying thanks to Dr. Balaji Bharadwaj sir, as a speaker and from JIPMER Pondicherry, has given lucid and wonderful presentation for the benefit of our pages. Many of our pages got benefited, sir, based on your session. And also I extend our gratitude to Dr. Bhavani Shankar sir from Pune, from Bhubaneswar, Odisha, and also my We extend our gratitude to our both moderators, Dr. Ashwath Babu sir and Pradeepa madam, as wonderfully moderate the program. And Easters Pharma always say thanks to Dr. Paneer Selvan sir as a course director, continuously doing for the past 2 years for the benefit of the PGs across India. The program is successful program. Today also we achieved 100 attendance from across India. The winners also you can see across India. And the same as sir said, the Easters Pharma always committed for the academic sessions. So for the YouTube link and everything, kindly contact our East West people. And also the winners will be, we also congrats for the winners. The winners also will be delivered certificate as well as the gift vouchers to all. Thank you for all. And once again, East West Pharma, we will see in the next Evolve program. East West Pharma wishes happy Diwali to one and all. Thank you so much, doctors.
Happy.
Thank you. Thank you.